Good morning or good afternoon, depending on what time zone you happen to be in. My name is Mark Perino. I serve as the president of the American Association for the Treatment of Opioid Dependence. Welcome to our webinar on how to expand the use of mobile vans now that the DEA has released the final regulations. So we are now going to get started very shortly. These are the DEA regulations, which have been posted, and you should have seen these already, but this is a resource. The other resources is my communication to the field, which followed the release of the DEA regulations. So at this point, what I'd like to do is introduce the panel. I'll make some introductory remarks as well. So the first point I'd like to make is that we worked in collaboration with the DEA for several years before this came to fruition. I know that our colleagues from the DEA, Scott Brinks and Claire Brennan, will walk you through the process from rulemaking to policy release. It was a long anticipated event, and we're really happy that it has come to fruition. We certainly are pleased with the work that we did with SAMHSA, the Substance Abuse and Mental Health Services Administration, and the White House Office of National Drug Control Policy, which is ONDCP. They were instrumental in getting this approved, and so I am grateful. Also, we've had ongoing discussions with all of the relevant federal agencies, NASADAD, the National Association of State Alcohol and Drug Abuse Directors, and State Opioid Treatment Authorities, because this is an ongoing collaboration, especially when you hear from our federal partners. And the issues of funding are very important. I know that Ann Herron is going to talk about how SAMHSA funding can be utilized for the purchase of the vans. We have other colleagues on the line from CMS Medicare and Medicaid authorities, because the reimbursement for the services are a critical part of the infrastructure in having this implemented and having this move forward. So let's get started. I want to introduce the panel to you. I will provide more detailed biographies as each of them begin to present. But to give you the lineup, it includes Scott Brinks, who is the section chief of the DEA Regulatory Drafting and Policy Support Section, in addition to Claire Brennan, who's the chief of the Liaison Section for the Diversion Control Division, Michael Santillo, who is the chief executive officer of the John Brooks Recovery Center, also Sean Soth, the Director of Health Integration and Innovation from the Evergreen Treatment Program in Seattle, Kathy Perez, the Director of Strategic Initiatives for the Evergreen Treatment Program, also Dr. Patty Juliana, Director of the Division of Pharmacologic Therapies for SAMHSA, and finally, Ann Herron, who's the Director of the Office of Intergovernmental and External Affairs and the Acting Director of the Office of Financial Resources for SAMHSA as well. So these speakers are going to guide you through rulemaking, how two programs have developed vans for a very long period of time, certainly over 10 years. And I'll talk about some purchasing options about the vans, and these resources will be given to you later, and updates on where we will develop the best practice guidelines, obviously in conjunction with state authorities, with SAMHSA, and any relevant parties. So with that, let me now introduce our two first speakers. The two speakers to begin with Scott Brinks. Now, he began his career with the DEA in 2001 after serving several years as a military police officer in the U.S. Army and later as a civilian police officer. Now, from 2001 to 14, Mr. Brinks worked as a diversion investigator in the Detroit Field Division and the Cleveland resident office. He worked for years for Tactical Diversion Squad and 11 years in the diversion group, conducting several large national and international pharmaceutical investigations. In 2014 to 17, Mr. Brinks served as the group supervisor of the DEA Maryville, Indiana resident office and the Springfield, Illinois resident office. He oversaw 6 diversion investigators and a number of national complicated pharmaceutical investigations. And during his tenure with the DEA, he's provided pharmaceutical diversion training to those in the pharmaceutical industry and hundreds of federal, state, and local law enforcement officials. In September 2017, he was reassigned to DEA headquarters, where he served in the policy section, liaison section, and the import-export section. In July of 2019, Mr. Brinks was promoted to his current position as the section chief of the DEA Regulatory Drafting and Policy Support Section. He's a graduate of Liberty Baptist Theological Seminary, where he earned an MA in Pastoral Counseling, and St. Leo University, where he earned a BA in Sociology. He's been the recipient of numerous awards and commendations throughout his career. We're delighted to have Scott with us. Additionally, and Claire will follow Scott, Claire Brennan is the chief of the liaison section for the Diversion Control Division of the DEA. In this role, Ms. Brennan is responsible for the liaison section, ensuring the program initiatives are met, and acts as a liaison with registrants like us and other parties in the prevention of diversion controlled services and activities. Ms. Brennan was hired by the DEA as a diversion investigator, and over her 24-year career has been assigned to the Newark Field Division, Camden Resident Office, and the Spokane Resident Office. As a diversion investigator in these offices, Ms. Brennan has directed or been involved in regulatory, criminal, and complaint investigations involving both pharmaceuticals and chemicals. In 2009, Ms. Brennan was promoted to the position of Supervisory Diversion Investigator of the Portland District Office, where she was responsible for the states of Oregon and Idaho. And in this capacity, Ms. Brennan was responsible for the supervision of 8 diversion investigators and ensured the goals and objectives of both the division and the Office of Diversion Control were being met. In March 2015, Ms. Brennan reported to DEA headquarters and was assigned to the synthetic drugs and chemical sections, where her tasks included assisting DEA field offices with information about emerging synthetic drugs and reviewing chemical and researcher investigations. In May 2016, Ms. Brennan was promoted to Diversion Program Manager for the New England Field Division, where she was responsible for the diversion program for 6 New England states. She received a Bachelor's of Science in Criminal Justice from the University of Scranton in Scranton, Pennsylvania. So it is my pleasure to bring Scott up as your first presenter. So Scott, it is all yours.
Thank you very much. So we decided to start this presentation with kind of a little overview of the rulemaking process and how rules are made, because as everyone is aware, the mobile NTP rule took a significant amount of time to go through the process and to get approved into the final rule, which we just did publish on July 28th. So I'm going to go sort of quickly through the rulemaking process so you can just kind of understand why it takes so long for this process to happen. When rulemaking is made, there has to start with what's called a triggering event, some sort of event that requires the DEA to write a regulation. The triggering event for mobile NTPs was people just wanted to have these mobile NTPs. There were some that were operating under an MOU with DEA. I believe there's 13 of them. And we needed to have regulations to allow these mobile NTPs to work under the DEA regulations and not under an MOU or an MOA. And then things would work out well. So that triggering event was the need for these mobile NTPs from industry, from Congress, and from DEA thought that this would be a great need to expand MAT treatment. So what DEA did was we first drafted the rule, and drafting the rule takes a significant amount of time, for sure the initial draft, because not only does it have to be researched and drafted and make sure that we meet all the statutory requirements and don't hinder any of our other regulatory issues. Once that rule is drafted, it's reviewed by several people in our agency, and once it's approved by the administrator, it's then sent up to DOJ, Department of Justice, where it is reviewed and approved by the Department of Justice. Once that's done, it's sent to the Office of Management and Budget, which is an executive office of the White House, where they review it. And while it's there, it is also sent out to all the other agencies that have impact on this regulation. So in this case, SAMHSA was one of them, other HHS offices, and they have 60 days at minimum to review it and respond to any questions or comments they may have. And that 60 days usually does run much longer than 60 days because we have to work through these issues. Well, once it is approved by OMB to publish, then we publish it in the Federal Register, which you guys all remember the notice of proposed rulemaking that was published. And then the public has 60 days usually to comment. And once the public has commented, depending on the amount of comments that are received, DEA reviews those comments, and all comments that are applicable to this rule must be addressed in the final rule. So it takes a significant amount of time to put all the comments together and then draft the final rule. Once the final rule is drafted, it goes through that complete process, again, DOJ approval, the Office of Management Budget approval, and it goes through interagency approval again, which is other agencies that have impact into this. Once everybody is in agreement and everybody agrees for it to go forward, OMB then approves the publishing of the final rule, which happened on July 28th with mobile NTPs. So typically a rule from beginning to end usually takes at minimum 2 years, sometimes as long as 6 years to publish in the Federal Register. So that's the basics of the rulemaking process. And I will turn it over to Claire next.
Thanks, Scott, and thank you, everybody. So I'm going to get into kind of the meat of the text of the registration requirements for a narcotic treatment program with mobile components. I don't have a presentation. I'm just going to be going over this with you. As Scott just said, it was effective July 28th of this year. And these revisions to the regulations, they were intended by DEA, to make maintenance or detoxification treatments more widely available. But also we have to ensure safeguards that are in place to reduce diversion. So what this did was it waived the requirement for a separate registration for narcotic treatment programs that utilize mobile components under certain conditions. So specifically under this rule, an NTP, or narcotic treatment program, as we call it, is permitted to dispense narcotic drugs in Schedule 2 through 5 from a mobile component at locations remote from, but within the same state as the NTP's registered location for the purpose of maintenance and detox. And this was deemed to be a coincident activity permitted under the NTP's registration. So again, if you have your brick and mortar registration, you do not need a separate registration to have a mobile component, but that mobile component must stay within the state of that registered location. And you may operate one or more mobile components. So how do you do this? You need to notify the local DEA office in writing of intent to operate and receive written approval from that office prior to starting the operation of the mobile component. And the regulations specify the type of vehicle. It must be propelled under its own motive power and lawfully used on streets, roads, and highways with more than 3 wheels in contact with the ground. Must have a valid county, city, state information, usually like, such as the VIN registration on file at the NTP. You must have safe installed, and it must have an alarm system that alerts an alarm company, a 24-hour control station operated by the registrant or law enforcement when an unauthorized entry attempt is made. And then there's operational requirements. So we already said this, but I'm restating it. Must operate in the same state as the registered NTP is associated with. Must only be supplied with narcotic drugs by the registered NTP it is associated with. You must not receive controlled substances from other mobile NTPs or any other entity. Must not deliver controlled substances to other mobile NTPs or any other entity. Must not conduct reverse distribution of controlled substances. And must have a SOP, a standard operating procedure established by the NTP to ensure that all controlled substances are accounted for, removed from the vehicle, and secured at the registered location if the vehicle becomes inoperable. and must comply with HHS Health and Human Services standards for quantities of narcotic drugs provided to enrolled persons for unsupervised use. So that would be the take homes. And just a little bit, a couple limitations to having a mobile component. You may not modify the registration to act as collectors, may not function as hospitals, long-term care facilities, or emergency medical service, and may not transport patients, and may not share, transfer, or reverse distribute controlled substances, like we had said earlier, to another mobile NTP. Storage requirements must not be accessible from outside the vehicle. So this is where you're storing the methadone or buprenorphine, or your Schedule 2 through 5 or 4, whatever other, if there are any other narcotics that might be used for treatment, must not be accessible from outside the vehicle, must be accessible to a minimum of authorized employees, must provide adequate observation when unauthorized people such as maintenance or any kind of visitor are in or passing through, must store the narcotic drugs in a safe installed in the vehicle when away from the registered NTP. And this safe has all the same requirements as those that you already have in place at your brick and mortar NTP. Must maintain control of the narcotic drugs when transferring between the registered NTP and the vehicle while en route and when dispensing. Must have patients wait in an area that is physically separated from the storage and dispensing areas. Must be returned to the registered location at the end of each day, and all narcotic drugs must be removed and stored in the registered NTP. It must be parked at the registered NTP or any secure fenced-in area, but that's only after the local office has been notified of an off location. So if it's going to another secure fenced-in area, the local DEA office needs to know that. And just like any other narcotic treatment programs and any other registrants, DEA has discretion on the degree of security when looking at the factors, like number of patients, security guard, all that kind of things. And then finally, the record keeping requirements must maintain a dispensing log at the registered NTP and kept for a minimum of 2 years. And this is all the same record keeping information that's already required of your NTP. So when you do the mobile component, and must follow the same registration requirements as must follow all the same requirements as the registered NTP for any automated or computerized systems. So really anything that you're already doing and you're familiar with the regulations as far as record keeping for your brick and mortar NTP is what you'll have to follow through for the mobile component. And I know that was a lot, but that kind of puts it in a nutshell of the overview of what you need to do for a mobile component. Thank you.
Okay, thanks very much, Scott and Claire. That's extremely helpful. Keep in mind for all of our listeners and participants, all of the panelists will remain throughout this program so we can respond to your Q&A. And so just to let you know that. I'll just say as an added note, I have always found our associates at the DEA to be truly collaborative. Throughout our history. We were founded in 1984. There were senior DEA officials at our opening conference in New York at that time, and that collaboration is extended during that period. I just find them to be very welcome in our policy discussions, and you can hear today why that is the case. So thanks again, Scott and Claire. Again, they'll be with us for the questions. So the next speaker, Michael Santillo, it comes at a perfect time, and I'll tell you why. We just got a question about how mobile vans can be used to support services in jails. So this question almost lays perfectly for you from my point of view. But let me tell you a bit about Michael. He's a licensed clinical alcohol and drug counselor with over 30 years of experience in the field. He serves as the chief executive officer at the John Brooks Recovery Center, which is one of the leading residential outpatient and medication-assisted treatment providers of substance use disorders in New Jersey. He has designed and implemented and supervised a wide array of treatment and recovery support services, including residential and outpatient substance use and mental disorders, medication-assisted treatment, mobile methadone vans, hence his presentation today, supportive housing services, recovery and sober housing services, jail and prison reentry programs, primary care services, and opioid overdose recovery programs, and community centers. He's also worked as consultant to the New Jersey Administrative Court and Public Defender's Office. He has served as a member of SAMHSA's State Best Practice Opioid Misuse Prevention and Treatment Panel and Recovery Research and Evaluable Technical Assistance Panel. That's a mouthful. And he's also worked as an administrative office in the courts of Drug Court Treatment Subcommittee and the Coalition of Addiction Recovery Supports and National Council for Behavioral Health Addiction Committee and Pew Charitable Trusts and the Bloomberg Opioid Initiative. So Michael is a fairly busy human being. We're delighted that he's able to join us. He, like his colleagues from Evergreen, are going to give you their history, a how-to approach. So this is the sort of provider group sandwiched in between the regulatory aspects. So with that, I'm delighted to introduce you to Michael.
All right, thank you, Mark. And it's exciting to be here for such an important webinar. So I think you can go right ahead to the next slide. So that's Jane Calabrese. She's the clinical director of our jail MAT program. She's been there since the beginning of the program. She's does a fantastic job, and that is our mobile van. So it's actually more like an RV. It's about the size of a school bus. And I just want to draw your attention to, there's that first door, which is where the driver goes in and drives the unit. And that second door I'll be referencing, that's where our clients go in and out. That's where they go for their physical exam and for the dosing. So I'll be referencing that. So you can go to the second slide. So there's just another picture of the van, but I do want to draw your attention to the fact that you can see the fenced in area there. It's bob wired on the top. So when we bring the van to the jail, we actually go into what's called the transfer station where they transfer inmates. And it's a completely secured, this picture is actually, we're leaving that secured area, but it's a very secured area. You know, you're entering really behind the, if you want to say, behind the walls of the jail. So if you want to go to the next photograph. And just to kind of give you an idea of what it looks like, Jane is kind of pointing to the complete back end of the, by the way, we call it the ROW bus. So ROW stands for Recovery on Wheels bus. And so that's actually the back end where we do physical exams. And those are done right on, face-to-face physical exams are done right on the bus. You can't see it, but there's actually an exam table there. There's a sink, there's a refrigerator, and obviously storage. So just to give you an idea of what it kind of looks like. If you've ever been in an RV, that's kind of, you know, it's that kind of a feeling. Everything's a little smaller than you normally see it. But that's basically what it would look like. So if you want to go to the next slide. So just to let you know what's actually in the mobile unit. So as I said, we have that backspace where we provide where we do physical exams. There's a exam table. We have Wi-Fi set up for computers. There's also a counseling space that's actually more toward the front of the bus, where we can do, you know, full admissions, intakes, and actually you could actually provide counseling services there. It can be closed off and can be private. We don't actually use that. We did use it at one point, and I'll explain that later. You'll also have a dosing station. So there's a closed off area where there is a pump that's linked to an electronic health record, our electronic health record. And there's also water supply there, and there is the safe with, you know, all the security requirements to store. I'm gonna be talking primarily about methadone, but because we do primarily prescribing of methadone. We do some buprenorphine as well and Vivitrol, but we provide all three MATs, but primarily it's methadone. There's also a bathroom area with a toilet and a sink. So it's well equipped to provide these services. A little bit about the licensing and certification. DEA approval is actually linked to our brick and mortar site. Although, we had to have all of our policies and procedures had to be pre-approved. And if we make any changes to any of our policies or procedures or any of the process involved in transporting the medication, dosing, providing services, we have to get that approved by the DEA. The state license is also linked to our brick and mortar site. Our state license is 2000275, and then they include in a separate license that MV1 designation. But basically, it is linked to our brick and mortar site, and we do have a separate SAMHSA certification for the mobile unit. So if you want to go to the next slide. So the original use for the Recovery on Wheels bus was that in 2008, 7 agencies in New Jersey were awarded contracts for mobile methadone units. We were one of those 7. And originally, the bus was used in the community. We parked it in a very easily accessible spot in the community. We did methadone and Suboxone inductions, which were really, on demand for anyone in the community. All of the intake, the physical exam was all done on the bus. We would go back to that site every day, and we would dose people every day. All of the individual and group counseling and other ancillary services were all provided at the main OTP, at the brick and mortar OTP. We then opened 2 new outpatient locations. And at that time, there was really no need for the row bus in the community. Most people were able to access one of our 2 outpatient programs. And so we were kind of sitting with the bus that was not being used, and also the state funding that was not being used. So we started to, brainstorm and work with the community to look at, how could we use the bus and the funding to provide greater access to MAT. So if you want to go to the next slide. So we started to look at the idea of using the bus and the funding to provide MAT in the Atlanta County Jail. And why provide MAT in a correctional setting? So we know that 65 or 63% of sentenced jail inmates meet the criteria for substance use disorder, and actually in the Atlanta County Jail it was more like 70, and that's compared to 9% in the general population. We also know that individuals with a substance use disorder are more likely to have additional contacts with the criminal justice system and reoffend upon release compared to those without substance use disorder. We also know that after a stay in corrections, the risk for overdose is enhanced due to reduced tolerance after a period of abstinence. And some of the research that came out of Washington State has said that within the first 2 weeks after release from prison, that it could be as high as 12.7 times greater than a similar individual in the general population. So that risk for overdoses is very high. If you can go to the next slide. A meta-analysis of 6 different studies actually found that there was a 3 to 8 times higher risk for overdose within 2 weeks of release from a correctional setting. Also, we know that acute withdrawal symptoms due to substance dependence are common in jails that require detoxification from illicit drugs upon admission, and that was true in the Atlanta County Jail. Even if somebody came in already prescribed methadone or Suboxone or buprenorphine or some form of MAT, they were forced to detox from those medications. And of course, the jails are not well equipped to deal with withdrawal symptoms. However, the Supreme Court did rule that withdrawal symptoms are a medical condition, and under the 8th Amendment, correctional facilities, including jails, are required to provide proper medical care to detainees. So some of the good news is that we know that individuals with opioid use disorder have a better chance of success, retention and treatment, and avoidance of continued illicit opioid use when they receive medication and behavioral therapy, or just medication assisted treatment alone. So if you can go to the next slide. And certainly, actually go back one. There you go. And certainly states have reduced overdose deaths among people released from incarceration through jail-based MAT programs. You can see those states. However, most of those programs use primarily just naltrexone. Rhode Island, however, offers all three medications, and they have since reported a 60% reduction in post-release for opioid overdose deaths. So we strongly encourage that if you provide these services, that you provide all three medications, not just naltrexone, but all three medications. So, and new researchers found that buprenorphine and methadone to be associated with reduction of opioid-related deaths, but not naltrexone. That was not. And in addition, research indicates that providing only injectable naltrexone in a correctional setting is not cost-effective due to the high cost of the medication. So again, we're supportive of naltrexone, but we really want to encourage people to use all three medications. Primarily, we are prescribing methadone in our jail program. So if you want to go to the next slide. So these were some of the goals of Project Kickstart, and that's what we call it, Project Kickstart. Program participants would continue MAT after release from the jail. So this isn't just about managing their withdrawal symptoms in the jail, right? We're really looking to kickstart or to start the recovery process through this program and have them continue once they leave the jail. We are looking, one of the goals was obviously to reduce recidivism. And another goal was to reduce the rate of overdose after release from jail. And our original target population was pregnant inmates with opioid use disorder already prescribed an MAT, inmates who entered the jail already assisted in their recovery with MAT, and inmates with opioid use disorder who will be in the jail a minimum of 10 days. Due to the success of this program, we actually revised that target population to really anyone with an opioid use disorder. So anyone with an opioid use disorder who enters the jail is eligible for participation in the program. Please go to the next slide. So just a little bit about the participant characteristics. So the median age is 34. 57% of the folks that we've served are male, 43 female, and the females are definitely overrepresented due to the fact that we do really emphasize targeting pregnant individuals. Prior to this program, pregnant individuals were actually escorted every day, were brought every day to the local OTP program in shackles. So here's pregnant women in orange jumpsuits in shackles, and they had to go every day to the OTP to get their dose and then brought back to the jail. So we're able to provide a much more humane way of providing this life-saving medication to pregnant women. It's all done right at the jail. So 50% of the folks that we served were either new to MAT or were restarting MAT after a period off the medication. Interestingly, when we started the program, that was 33%, and that's increased as we have expanded services to more and more people and have expanded access. So 50% are new, and 50% are folks that are already coming into the jail, prescribed an MAT, and just it has 14% are guest dosing. And when they come in already prescribed the medication, then we're actually guest dosing them in the jail. About 14% are JBRC clients, and 36% are guest dosers from other agencies. So if you want to go to the next slide. We've served 1,328 individuals, 1,169 individuals were released to the community on MAT. 82% have begun treatment in a community-based MAT program. That number is actually is a little distorted because about 10% of the folks actually go from the jail to state prison. So that's a little, and we only count the folks that actually go into the community. In the state of New Jersey, as a result of the success of this pilot project, and this is at the county jail, now all of the state prisons are providing MAT. And so we can initiate or continue somebody on MAT in the county jail. And when they go to state prison, that medication will be continued. For the first 2 years of this project, and this project started in like 2017, if they were going to state prison, we either had to titrate them off of their MAT or we did not do a induction. So this is good news, but that number's a little distorted. But our research showed that prior to this program, only about 30% of folks were actually following up and engaging in treatment once they left the jail, and now we're at 82%. So for the people released into the community, the length of time continued on MAT. We do follow-ups. We know that about 43% continue MAT for at least 3 months, 26% for 6 months, and about 19% after 9 months. So if you can go to the next slide. What we've also found is that recidivism for the folks involved in the jail MAT program, Project Kickstart, it's about a 44% recidivism rate, where for the average population in the jail, it's about 65 to 68 recidivism rate for the general population. That's been pretty consistent for about 10 years. So we have seen a reduction for the people involved in this program. Interestingly, most of the people who do wind up being reincarcerated, it's not for their SUD, it's for other issues like non-appearance in court and in other charges that are generally not related to their SUD. So a number of persons known to have overdosed. We do follow-ups on every client, and we're only aware of one non-fatal. The person was reversed. So, that's fantastic. We also surprisingly saw a 65% decrease in suicide attempts, which was completely unexpected. We didn't expect that at all. And we saw 75% decrease in withdrawal complications requiring ED visits. So if you can go to the next. So that's just kind of some of the background to show you the effectiveness of the program, how successful it's been. And I just want to kind of walk through a little bit of the procedure and what actually happens. This is not a step-by-step. There are kind of two processes happening at the same time. There's the processes and procedures that are happening on the bus, and then there's the things that are actually happening in the jail. So this is not a step-by-step, but it'll give you some sense of what the process is. So our driver, and I want to really, because this is important, that person's also a person in long-term recovery, and she plays a much larger role than just being a driver. I've witnessed this. I've been on the bus many times. She really helps to engage clients, and she really acts as an assistant to the APN and to the registered nurse. She does a fantastic job. But she'll drive the bus from where we park it overnight at our residential facility, and she'll park it to our OTP located in Pleasantville. There, we'll transfer the methadone and other MAT to the safe on the bus. And that's done with 2 registered nurses, the registered nurse who's actually assigned to the bus, stationed on the bus, and another registered nurse. They'll transfer the medication from the OTP to the bus, and then go to the jail. And then when they're done dosing, the bus will return to our OTP, and the medication will be transferred back to the OTP. So in addition to the driver, there's also the RN who's stationed on the mobile unit, and she is responsible for the methadone transfer and dosing. And as I said, we return the medication goes back to the OTP at the end of the, after they complete the dosing. We go to the jail 5 days a week, Monday through Friday. And if you want to just go to the next slide. And on Saturday and Sundays, we give take-home bottles, which are dispensed by CFG, the nursing department at CFG. They're the contracted medical provider for the Atlantic County Jail. So they dispense the take-homes on Saturday and Sunday. Generally, we do, the dosing is in the early afternoon. So we usually arrive at the jail around 12, and we'll dose established clients first, and then they are returned to their cells. And the process takes about 3 hours, and I'll explain that in a little bit more detail. New clients then enter the bus one by one, and they receive a more comprehensive nursing assessment, physical examination by an MD or an APN, and if they're appropriate, they will receive medication that day. So if you want to go to the next slide. So that's happening on the bus. In the jail, basically when somebody first comes into the jail, CFG, the medical provider, they'll do a physical exam and nursing assessment. And if that person has any, is currently on prescribed any MAT, or if they have any opioid withdrawal symptoms, it's put into their the jail computer system. So there are alerts that are sent to our JBRC staff. Our JBRC staff, then they complete an assessment to determine the probable length of time that the inmate will be in the jail. As I said, we no longer have that 10-day requirement, but it is important to know how long the person is going to be in the jail, or to try to calculate how long the person is going to be in the jail. If they're going to stay prison, there are arrangements that we have to make. We have bail reform in New Jersey, so some of the folks are in and out of the jail in a matter of a couple of days. And so we want to make sure that we know how long they're going to be in there and how much time we have to set up a referral and linkage to a community-based provider. Eligible candidates who want to be in the program are then scheduled for admissions. You can go to the next slide. Our counselors then conduct a full admission, which includes, it's all the requirements that you would do in any OTP program, the biopsychosocial, education regarding MAT, all the admissions forms. It's all entered into our electronic health record, and the NJ SAMS, which is a New Jersey substance abuse monitoring system. The inmates are moved from their living areas and staged in the court transfer station prior to the bus arriving and locked in holding cells. So this is where things get a little bit difficult, and why it takes so long to medicate folks, is because what happens is they take cohorts of 5 inmates, bring them down to this state, to the transfer station, put them in a holding cell, and then one person enters the bus at a time. They're dosed, they go back into the holding center, and after we've served those 5 individuals, they have to go back to their cells, and then another 5 are transported down to the transfer station. So it takes a long time. If we're dosing 50 people, it takes 3 hours to at least to get through that process. So if it's a new person, then again, the medical doctor or the APN performs a full physical exam. They review all the lab work, and we will do the dispensing that day. So if we can move to the next slide. So we're not only, I hope that gave you some sense of what that process looks like. We're not only providing MAT, and I think that's important. We believe that medication is essential, and if we can only provide medication, we would only provide medication, because we believe that this medication is life-saving. But we also believe that it's important to also provide counseling services. So we do provide counseling services. All the inmates are scheduled for individual and group counseling services on a weekly basis. Those services, though, do happen not on the bus, but they happen in the jail, and they happen in designated areas that are licensed. So we have to actually license designated areas through our state licensing in the jail so that we can provide the assessments and the group counseling, individual counseling. It has to occur in those licensed areas. The dosing and the physical exam has to happen on the bus. And that's the way our licensing has determined how that process works. I don't believe that's DEA. I think that has more to do with our state licensing. But our state licensing has been very clear that the physical exam and the actual dispensing of medication has to happen on the bus, can't happen in the facility, especially inductions can't happen in the facility, and that the counseling services can happen in the jail, but they have to be in these designated areas. So not only do we provide the counseling services, but in addition to those traditional counseling services, we also provide care coordination through case managers and peer recovery services through peer coaches, peer recovery specialists. So those services also start in the jail. They engage with the clients in the jail. And then most importantly, and we believe this is very important, is that they follow the individual into the community and continue to work with the individual in the community to ensure that they're engaging in services, accessing benefits and social service opportunities, are engaging in the recovery community, that their health needs are being met. I mean, that full array of care coordination and peer recovery supports follows them right into the community. Actually, we will actually pick them up at the jail and drive them to wherever they need to go on that first day that they are released. And of course, every client upon release is referred to a OTP program that is most convenient to them. Many of them do come to our programs, but a percentage do not. So if you can go to the next slide, just a couple of ongoing challenges. As I mentioned, inmate movement and dosing can be very time consuming because of the security issues. And this restricts some of the availability for counseling, and certainly COVID had made that situation worse. The other challenge that we still see is the officer bias and stigma regarding MAT, especially methadone. And so you have to be very careful about choosing the right corrections officers. And we have found that it's really important to do ongoing in-service training for those corrections officers. The next slide. And just a couple of ideas in terms of potential opportunities moving forward for mobile units. So just like we're providing driving to the jail and doing methadone inductions, Suboxone inductions, providing daily dosing, and physical exams and so forth. I think that same service could be applied to residential treatment programs. In the state of New Jersey, residential treatment programs, including halfway houses, cannot do inductions. And so, that's a service that could be provided from the mobile unit. Also the daily dosing. And a lot of these programs, they are clinically driven and not medically driven, so they don't have the medical staff. They don't have the expertise. They may not have the funding available. And as I said, some of the state regulations prohibit them from providing these services. So I think the mobile units could be used the same way we use it at the jail. And it obviously would be a lot easier because you don't have all those security issues. But certainly residential programs, halfway houses, which are clinical in the state of New Jersey, they're licensed under residential treatment programs, but also recovery and sober living residents and outpatient programs. I won't speak to rural areas because I think that's the next presentation, but I think there's a lot of additional opportunities to expand access to MAT, working with other treatment providers and recovery housing programs and outpatient programs. So I think that's it, and thank you very much.
And thank you, Michael. That was excellent. It was exactly the comprehensive overview I was looking for. So I appreciate that. Your experience is golden. And we do have questions. So for the audience, we are keeping track of them. We will put the questions you've asked to Michael and also to the other presenters who are now soon to follow. So now we go to Evergreen Treatment Services in Seattle, Washington. I've been working with that group for 25 years, going back to when Ron Jackson served as the CEO and then over to Molly. So we have two presenters, and I'm going to read their bio sketches as well, since one will follow the other. So Sean Soth has been working in substance use disorder treatment for 12 years with experience in inpatient, intensive outpatient, co-occurring, and MOUD. Sean received his bachelor's in sociology and ethnic studies from Central Washington University and went on to complete studies to obtain his counseling credential. As a teenager, Sean's mother was a communicable health nurse amid the AIDS epidemic in a small rural town in Central Washington. The experience of seeing individuals marginalized and stigmatized clearly left an enduring mark on Sean's life and cleared a path to his work today. He's been with Evergreen Treatment Services for 6 years, and in his role as the Director of Health Integration and Innovation, is focused on providing access to high quality, low barrier treatment services. Throughout his tenure with ETS, Sean has led the development and implementation of case management services, peer services, and community-based rapid access to MOUD, all with a continued focus on compliance and quality. Now to Sean's associate, Kathy Perez. She's been with ETS for over 5 years. She started out as a clinic manager and has been working in healthcare management for the past 15 years. She enjoys building relationships with communities and educating them as to what we do, and that's extremely necessary always. As I've said to my colleagues throughout my tenure, we always have to educate people about what we do. We can take nothing for granted. So it's my pleasure to introduce Sean to begin this part of the how-to presentation before we go to our SAMHSA associates. So Sean, welcome.
Thank you, Mark. Appreciate that. Very excited to be here. And Michael, I definitely enjoyed hearing your presentation. There's so much that we do in common that it's pretty amazing to hear the great work that other folks are doing. So like Mark said, I'm Sean Soth. I'm Director of Health Integration and Innovation. I'm going to talk a little bit today about the different iterations of our treatment and motion, or TIM program, as we call it. Somewhat like ROW, but just a little bit different. And then Kathy will pick up our Director of Strategic excuse me, I'm sorry, I'm getting confused by the switching of slides there. Our Director of Strategic Initiatives will pick up and talk about the importance of community relationships and how we develop those. Our program is focused on community-based access to MAT services. And so we'll talk a little bit about the history because we've been doing this for a while. Next slide, please. So ETS started this process back in 1999. We had a mobile methadone treatment services grant through CSTAT that partnered us with some public health clinics in our local area, in the Seattle area. One was just north of Seattle in Northgate, and one south in Renton, so kind of just bordering the Seattle area. Those programs, like I said, were connected to the public health clinics and offered us an opportunity not only to provide the mobile access to the dispensary, but also provided an opportunity for us to share space and offer counseling services in those clinics. All of the inductions and initial intake were completed at the brick and mortar location for that program, but the other services we were able to provide remotely. That program lasted until about 2004. At that time, the grant life cycle had ended. And so funding was an issue for our partners. They also were expanding and needed the space that we were taking up in their parking lots. And so that created a change in our approach at Evergreen related to how we were providing services. And one of the changes was we still had community partners that were allowing us to park our unit, but we did not have the same relationship with those individuals in terms of providing some of the ancillary services at those locations. And so during that time, we found that we didn't build the same kind of community relationships, and we ended up moving locations quite a few times between 2004 and 2011 into different areas of the city, downtown and around the city at that point. So in 2011, we then realized due to multiple different factors that we had to change how we were providing service again. And this really fell back on one, we recognized that our population was changing. We had higher need population, and we were not able to provide all of the services that we recognized were needed through the mobile structure that we had at that time. And that combined with a real staffing shortage in our area for both nursing and counseling, we decided at that point to pull the van back, and we had it parked at our Seattle location. We utilized the van still at that time, but the utilization was really as an additional dosing window so that we could expand access at the clinic because we have limited space there, so that we could continue to serve additional individuals and provide the medical provider time and counseling that was needed for those individuals that we were just not able to do at our remote locations without that partner relationship that we had had. So from 2011 until 2018, we had the van parked out back. In 2018, we can go to the next slide. In 2018, through some grant dollars in conjunction with King County, City of Seattle, and SAMHSA, we were able to purchase a new van because our old van had been used very well and loved, and we needed some change. So we were able to purchase a new mobile dispensary, as well as a counseling and medical van. And so our lessons learned from our previous experiences really led us to the development of this structure where we had the mobile dispensary that we're able to provide methadone and buprenorphine through, and then the secondary van, the counseling and medical van, where we have access to the medical provider and behavioral health counseling opportunities in those mobile units. And we really structured this so that we could roll those out together so that we had all of those services in one, with the recognition that we had learned from our past was that those services were a necessity and we needed them in the community with us, that having that separation of services was not effective and didn't allow us to meet the needs of our patients and didn't allow us to meet the needs of the community around us. And so that was our opportunity to expand the services that we were providing. Next slide, please. So in this new iteration that we rolled out in 2018, we really chose to focus on specific areas. We wanted to go into low service areas. We wanted to make sure that we were focused on underrepresented communities that didn't have access to treatment as readily. Wanted to make sure that we were focused on low income areas. And based on our expertise with partnering programs, we wanted to ensure that we were providing access for homeless populations in our community, which everyone knows is a growing issue, especially in urban areas. So the idea was to expand access through community-based rapid access to MOUD services. This was really a concept based on direct street-based services that ensured that we had a team providing same-day access as much as possible to all MOD services. And we did that through combining case managers and counselors, nurses, and we do have public safety individuals that are part of this program as well. We use 2 public safety folks on our van. One of them is the driver, and then we also have one that is kind of street-based and maintains just kind of an eye on the community as we're serving our folks. Next slide, please. So just a quick look into the TIM program. This is the inside of our counseling and medical van that you're looking at. The left-hand picture is just the exam room that we have so that folks can come in, see a medical provider, go through the exam process, and all of that's available. The middle picture shows you kind of the pass-through from the front office space, which is on the right-hand side, and that is just an office space with a little desk for counselors and case managers to be able to have the opportunity to meet with patients. So 2 office spaces there for us to work out of. The next slide will show you the dispensary van, next couple slides actually. So the first picture here is just the entrance to the dispensing window. Folks walk in, shut the door. It's a secure door. And you can see the plexiglass there that separates them from the nursing station, which you see from the other side in the middle picture there, where our nurse works from. The last picture on this slide, you can see the safe that's a part of our unit, as well as some space for our staff to be able to hang out. And then you also can see our security panel is there. This is the same security system that we use within all of our brick and mortar system. We have a panic button for our nurse to be able to use. And we're looking at ensuring that our driver has an opportunity to have access to a panic button in the cab of the vehicle as well. And that's all centrally located to the alarm system company. The last picture shows you kind of the back end of the dispensary unit, where we actually can perform UA collection as well. So we've have a restroom there, and our security staff will double as a collection team so that we can still collect monthly random UAs from our folks that are getting services on the mobile unit, which really allows us to be a fully mobile provider at this point, which is just not something that we had the ability to do in the past, and it's something that the new units gave us the opportunity to do. You know, the biggest lessons for us in this process have really been focused on the community relationships. It is without a doubt the most important part of the work that we're doing, and our experience from the past taught us that those relationships with the folks that we are pairing with are extremely important and are probably the most telling sign of success in the community. From 2008 until we had to shut down TIM because of COVID, we were struggling to get people to access on the vans. And one of our experiences was that in one location we were not able to utilize space and connect with the folks that we were parked outside of in terms of a location. And we really struggled to get individuals enrolled into the program and taking advantage of the remote access through the TIM program at that location. At our other location, we had an opportunity to utilize space with our partner, an outreach team in our downtown core. And in that location, we saw a consistent growth of the number of folks that we were dispensing to through our mobile dispensary. And I think that speaks to the importance of those relationships and connections to the community, and how that provides an opportunity for them to have conversation with the folks around the area and really build those programs together. And so I'm going to hand it off to Kathy Perez, who will talk more about how she did a ton of legwork to develop those relationships and get us connected to the community.
Thank you, Sean. Good morning, everyone, and welcome. So a couple of things that we took into consideration when we were planning our community relations, as you'll see in throughout the slides, that we had to define and develop a plan, and a plan also to engage and educate the community, because as Michael said, there's even a lot of officers that still have the stigma, and we want to be able to educate everybody on the importance of what we do. Then we also want to monitor and maintain the communication relations with our community stakeholders. Next slide. As we took the time to define and develop, you'll see a list of activities that we took into consideration. Notably, notify and engage legislative authorities, identify stakeholders, as you'll see in the next slide, who those stakeholders should be, identify community liaisons, that's very important, and identify a community relations coordinator who would be the go-to between the community stakeholders and our organization, and also develop a mitigation strategies. Next slide. As you can see, these are a list of our community stakeholders that we felt were very important to engage with, such as local health organizations, substance use programs, social and health services and agency directors and physicians. We also went out into the businesses and talked to their leaders, literally knocking on doors and giving them pamphlets and letting them know that we wanted to come into their community. We also reached out to community and health planning agency directors. Also, it was very important to connect with the grassroots communities, because they are the ones that are pounding the pavement out there, and they know where our most at-risk patients and populations are. So it was very important to build those relationships with them. Also, neighborhood associations and be involved in their meetings, school boards, local police and law enforcement officials. As I can tell you from my experience, I was able to build on a relationship with one of our local police departments, and I was able to do ride-alongs with them and educate them and let them know where we were located at our newest site, and build a really good relationship with them. And that gave me the opportunity to do other programs with them. And in doing so and riding with officers on the ride-alongs, there was still some officers that felt that there was a lot of stigma, and they felt that our medication was just getting people high. So we were educating them that this was a disease and the importance of us being in the area and how we could partner with each other. Also, fire departments, emergency management office, and local churches and spiritual leaders. We had the opportunity to park our van outside a local church, which happened to also be an office for a local needle exchange, which they felt that we needed to be there. And we worked on building those relationships and helping in that community as well. Next slide. When it comes to engaging and educating, it is very important to have the literature ready to show who we are and what we do, not just about the mobile van process, but also to recognize the importance of an MOUD and MAT services. As you can see, we had to deploy a liaison and a coordinator, distribute communication literature, solicit community and stakeholder input. And also we wanted to be able to address concerns on an ongoing basis so that we were able to meet the needs of the community. Next slide. Here's just an example of some of the pamphlets that we hand out. It tells you about our mission. It talks about how you can get connected to services if you're in need of services. And it tells you about the services that we provide in our organization. Next slide. So we also wanted to identify a point person, as I mentioned before, for an ongoing communication between the organization and also community leaders and stakeholders. That's very, very important to continue those relationships. I can't stress that enough. We recognize the importance of knowing what is happening and being able to and willing to adjust to what is happening in our community. And it's a benefit for having the mobile van out there, knowing what's going on and where we're needed. You'll see that we put in community concern logs. We did monthly reporting. We had an open line of communication with our point person between the community stakeholders and also our organization. And we were able to document, evaluate efforts that were going on in the different communities. Next slide. So this year, it might be really important to partner with a community health organization. But next year, we might find that relationships are not as needed with, and they need more relationships with maybe a local food bank. Especially with COVID going on and everything, it took a turn for not the worst, but I would say that we had to look at things differently. And we need as an organization, a community of stakeholders to have these communications and the ability to adjust where needed and to move where we are needed. And that's really what this is all about having the van out there and how we can service the different communities. And again, the communication and relationship building, because, when I can remember when we first opened up our newest clinic in a smaller city outside of Seattle, we had a lot of naysayers and thought that we were going to bring a lot of problems to the neighborhood. And in fact, we brought a lot of solutions and a lot of partnerships, and they saw that we were helping instead of being the negative person in the community. Thank you.
So thank you to both Kathy and Sean. You'll notice as participants, the complementary nature of what Michael presented and what Sean and Kathy presented as well. And so I know that, again, there are questions coming in. We will have the period for the questions to get answered, and we're keeping track of them. So now it is my pleasure to present our SAMHSA associates who complete the sort of panel that we've presented, which started with the DEA, went to provider experiences, and now to SAMHSA to provide some guidance. There are two SAMHSA representatives joining us. I'll introduce them both. Dr. Patty Giuliano will start first as the director of the Division of Pharmacologic Therapies within CSAT SAMHSA. So before joining SAMHSA Center for Substance Abuse Treatment, Dr. Giuliano was a clinician and administrator with extensive experience in hospital and community-based opioid treatment services. She began her career at the Albert Einstein College of Medicine in the Bronx of New York, where she focused on the treatment of families affected by substance use and the needs of people who suffer from medical and mental health problems, along with substance use. There she served as the Assistant Executive Director of the Division of Substance Abuse, and then became the Administrative Director of the Mount Sinai Beth Israel Addiction Treatment Services, where she led a continuum of addiction treatment services, including 21 MAT facilities. Dr. Juliana received her doctorate from Adelphi University School of Social Work. She is a clinical social worker licensed in New York and Connecticut and is a certified trauma professional. She conducted research studies at Albert Einstein College of Medicine and Mount Sinai Beth Israel, and has published in various journals and textbooks on issues related to families and substance use. Patty now leads the DPT to manage the day-to-day oversight activities necessary to implement federal regulations on the use of substance use disorder medications, such as methadone and buprenorphine, and the treatment of opioid use disorder. And in my discussions with Patty, I know that she is dealing with a whole bunch of issues just like we are. Also, we're going to be joined by Ann Herron. She is the Director of the Office of Intergovernmental and External Affairs and the Acting Director of the Office of Financial Resources. Ann Herron currently serves in this capacity. The activities of the office include establishing and maintaining collaborative relationships with federal, state, tribal, and community health providers in order to disseminate SAMHSA resources and to inform the development of SAMHSA policy and program. The office engages in liaison work in such areas as disaster and emergency management, service members, veterans and military families, tobacco and health, financing and regulatory affairs, policy coordination of block grants, management of SAMHSA's national advisory councils. In addition, their duties include the leadership of the Office of Tribal Affairs and Policy, the Office of Behavioral Health, Equity, and the International Global Health and Territorial Affairs. The office is responsible for the overall direction and management of SAMHSA's 10 regional offices located across the country in the 10 HHS regions, offering consultation and a local resource for the range of public and behavioral health stakeholders. Prior to this position, Ann served in a variety of positions with SAMHSA during her 18-year tenure, including Director of the Division of State and Community Assistance, Director of the Office of Program and Policy Innovation, Acting Director of the Office of Communication, and Acting Director for the Center for Substance Abuse Treatment. She is also, like Patty, a truly remarkable resource. Like the DA, we are very happy to call them colleagues. You will find that from both Patty and Ann, they will give you an understanding of how mobile vans can progress and funding that can be allotted. So with that, I'm happy to introduce Patty Juliana to you.
Thank you, Mark, and thank you, Michael and Evergreen, for such informative presentations. It was really wonderful to hear. And I have the simplest part. I have the go forward. Angela, if you could first go to the next slide. So my part is, what do you do now if you are interested in, if you're an OTP, interested in applying to add a med unit, which I'm looking forward to seeing many applications for this. The first step, please talk to your SOTA, your State Opioid Treatment Authority, regarding your interests. That would be best place to begin. The next step is that your program sponsor needs to go to their extranet account and open it to apply using an SMA 162. You'll see that there. When you click on the red circle, SMA 162, next slide. Angela, thanks. You'll see this is what the application looks like. For now, you would click on medication unit. In about a month, there'll be another button that will have a mobile van choice of a mobile van. Take it from there. You will need to add some documents. Next slide. We'll be looking for a couple of things. One is a description of how you'll be receiving the medication supply from the primary facility. We do need a statement that the sponsor agrees to retain the responsibility for patient care, that won't be transferred to another organization. We need to know the size of the medication unit and a description of the facilities, total number of patients to be served by the primary OTP and the medication unit combined. But we also need to know how many will be served at the medication unit only. We'll want a justification, or need a justification for establishing a medication unit, the name and the address of any other active medication use that the OTP and the name and address of any other medication use the OTP might have. And so with the last slide, if you find yourself stuck with accessing the extranet, your extranet account, or if you need any other specifics, please do call your OTP compliance officer. We're happy to help with all of this. And let me preempt one set of questions, if you will, and that is the regulations themselves. I know this will be coming. So the regulations themselves say that the don't limit what can be provided, but we have guidance on the web pages and in the federal guidelines for OTPs that specify medication only. Part of the reason that we're here now is to learn what you might want to do. That has been the policy, but we want to hear what you're interested in doing. And most importantly, please remember that our primary goal in helping with applications is to improve access to medications for opioid use disorders. We are looking forward to helping to turn around the direction that our country has been going as far as services. So that is my brief part, and I will turn it to Anne to continue with the how-to.
Thank you, Patty. Thank you, and good afternoon, morning, everybody. It's a pleasure to be here. I wanted to just recognize those two examples of really fabulous programming, and really gives us a sense of the opportunities and the potential we have to transform not just the where and how we provide services, but really expand the access to the kind of life-saving medications that people need. And so my part of this is to talk a little bit about what options exist for the use of SAMHSA funds. And so I wanted to give you a sense of what we can and can't do, and maybe some workarounds on a couple of those things. So let me start with SAMHSA grant funds can only be given, as many of you know, to nonprofit organizations. And we're aware we've had many discussions about what we can do around that limitation that we have. And quite honestly, there's not a whole lot that we can do. But for those of you that are nonprofit and are eligible to receive SAMHSA grants, it is not uncommon for us to include vehicles in the approval of budgets in our grants. We often look at kind of balancing whether purchase or lease is something that is what's more cost effective. But that is something that we have been doing for a number of years and will continue to do. So I wanted to let you know about that piece. The second piece, if you are a for-profit, which we know many of you are, we cannot give you grant dollars. However, we have just recently resent some guidance to the state substance abuse authorities about the ability that they have to use block grant funds, not in a grant perspective, but as a contract activity to assist and to support the purchase of vehicles. It's clearly within their authority to do that, not do that, whatever would fit into the plan that the state authority has for their state. But it is a fiscal allowable cost for them to engage in a contract with a for-profit entity. So that guidance went out to states last week, and so that they have that. And I wanted to let you know that that is something that may be worthwhile having a discussion with either your state authority, with other entities that may be applying for SAMHSA grants, who could in turn subcontract with you for a vehicle or for some services. But that is something that is an option. So I would open it up at this point to Mark, and however you would like to handle questions for the panelists.
Okay, thanks again, Patty. And Ann, just to be clear, what Ann just said is not a small sort of issue. It's a significant matter. And as Ann advised, if programs wish to develop mobile treatment programs, absolutely, as Patty said also, you need to begin in talking with the state opioid treatment authorities. And I know that our colleagues at NASADAT are listening into this, including Rob Morrison and his associates, and a number of the state opioid treatment authorities as well. And so all of this information is being provided basically in a fairly coordinated manner. And so what Ann said about the for-profit entities, that is guidance that will continue to flow with the state opioid treatment authorities and, of course, the state alcohol and drug abuse directors with guidance from NASADAT as well. So as you can imagine, this is a fairly complex puzzle piece, but an important way of moving ahead to increase access to care. Certainly, this administration, whether it's the White House Office of National Drug Control Policy, HHS, DEA, all are in sync in wanting to increase access to care. And has been explained in prior discussions and reports, the fact that we have 90,000 Americans dying of opioid overdose is got to be changed and reversed. There are many components of that, but in this case, the whole point of this discussion was to give our field a how-to understanding of how to do this. So there are a couple of questions. First to, I think, Michael, Sean, and Kathy. Question came up of, did you have to deal with any zoning restrictions with regard to the use of these vans?
So I can answer part of that question. We did have to partner up with our city leaders to get permits to be able to park our vans in the different locations.
Anyone else?
We did as well when we were providing those services in the community.
Okay. This is a question for Michael. Is security on the bus at all?
So we have our driver, we have an RN, that's it on the bus. The medication is locked up in the safe. We have all the required security features on the bus. And then, of course, when it's brought into the jail, it's in a secured area.
For us, when we're in the community, we do have two security folks that work with our program. One of them stays in the cab as the ability to get out of Dodge quickly if needed. And then we have one that's street-based that kind of just walks the community, has conversations with folks, those kind of things.
Okay. Another piece that's come up, you presented the vans, the cost of the vans. And I know this varies, but it would be helpful. And I know that you've had vans for a while, but what guidance can you provide to the OTPs, your colleagues, about what they should anticipate in the cost of vans?
So, yeah, I mean, our van goes back to, or our bus goes back to 2008. And I don't have that number in front of me, but I've based on what I've read and what I've heard, you know, you could be looking at the 200,000, depending on the 250,000, depending on how you outfit the van.
Yeah, and that falls right in line. We purchased our van back in 2018, and the mobile dispensary cost us 200,000, and then we have the mobile medical and counseling van. That van cost us about 150,000. So that, you know, it's probably a little more expensive today because we're a few years later and in the midst of COVID, but that's where we were at in 2018.
Right. And that's in line with my recent discussions with manufacturers of such units. I know that we have a colleague in Rhode Island at Kodak that's about to launch this. I believe that van was well over 200,000 as a unit. Again, this depends on the complexity of the van, the services that you're going to offer. There's also a difference between, for lack of a better way of putting it, a refurbished van that starts with a chassis and then builds to a OTP's component requests. Also, again, it depends on, again, lack of a better way of putting it, the various bells and whistles that will be used. Obviously, to maintain compliance with federal agencies like the DEA, clearly you have to plan this. And so that's simply the cost, but that provides guidance. Obviously, AATOD will be providing guidance and further information. We're going to work under the Opioid Response Network initiatives, working with our associates who manage that from the American Academy of Addiction Psychiatry. For many of our colleagues, you know that ORN has been incredibly helpful to us. This is one of our projects within the ORN initiative. So as we develop clinical practice guidelines, providing real component information, like what are the leading manufacturers of these vans? What are the costs of the vans? This is AATOD's idea of basically getting this done, because if our federal agency counterparts know, the publication of final rules and regulations is phase one. For us, this is phase two, which is the rollout, the implementation, which is why this is a kickoff webinar to do this. Next question has come in this is more for the DEA. It's the issue of mobile vans returning to the base OTP. I know that in your June 28 publication, you get to the issue of vans returning to the base, which is typically what you would prefer, but there can be an exception, and that exception has to be filed. Can you explain, Scott and Claire, what if the van at a purely practical level is traveling a certain mileage or a radius away from the hub OTP site, whatever that mileage is, where there are certain practical cases where the van would not necessarily return to the hub site at the end of the day, which is currently the description of how both the Evergreen and the vans that Michael has in John Burke's facility in New Jersey. So what guidance can you provide to the state authorities who are on the phone, to your associates at SAMHSA, and to the providers about if a program is going to use a van and it's not practical for the van to return to home base at the end of the day, what is it the OTP would have to do?
You want me to take that, Claire?
Yep, go ahead.
Okay. Yes, if the OTP wants to stay out overnight, they're going to have to submit what's called an exception to regulations to DEA. That can only be approved by the assistant administrator for the diversion control division. That would give you an exception to our regulations in order to stay out overnight. DEA is going to take those requests on a case-by-case basis. There's a lot more things that we'd have to look into with security, with the more methadone on and staying overnight and things like that. So if an NTP would like to apply for that exception, they have to reach out to their local field office and they will start the process to do that.
Okay, anything else on your side, Claire?
Nope, that was covered.
Okay, great. So this is a slightly complicated question. I think this is really going to be more for SAMHSA folks. So it would appear, this is the question, that mobile unit operates as a full OTP, completing intakes and counseling, not simply a medication unit. We have been informed by SAMHSA that mobile units are medication units on wheels and cannot provide these services like counseling and medical. Do you need a separate waiver from SAMHSA to provide these separate services? Now, again, before you answer the question, and Patty and Ann, and I'll say this to the people on the line, keep in mind that there are two different entities. One is the mobile van component, was the subject of today's discussion. There's a separate issue, which are the use of satellite medication units. Now, these are bricks and mortar facilities. These are not mobile units. The key here is both the mobile units and the satellite medication units would be connected to the OTPs as the central hub site. So in this case, the hub site of the OTP will have spokes. One of the spokes is the mobile methadone unit or medication unit, said with all three medications, and then the satellite medication is separate and apart. We will be getting clarity certainly from SAMHSA about these issues, because it is important in increasing access to care to fully understand the rules of the road. And since AATOD is working on a current policy component paper, these issues come up. There is confusion right now about the use of satellite medication units. Many people are of the view that it's specifically medication and collecting tox samples. And so while this question goes to what services can be provided on the mobile units, and again, does SAMHSA need to provide separate sort of registrations or guidance? I leave it to you.
So I can jump in there, and just as there are two issues, medication units and mobile vans as mobile medication units, there's also two separate issues here. There are the regulations, and then there's policy. The regulations do not limit, if you want to go back to them, they do not limit the services to be provided. However, it has been the policy of SAMHSA to, as described in the federal guidelines that were compiled by many experts in the field and reviewed by many experts in the field, again, and then re-revised, they maintained that all that could be done is policy-wise is medication dispensing and toxicology specimen taking. That said, though, we are in a different environment. We are in a different period in history, and there have been many, we are definitely in trying to mitigate the current opioid epidemic. And so in that spirit, we are considering what we might want to do and what we might want to limit. So we want to hear from you as collectively, not just you, Mark, sorry, but from you collectively about what it is you would like to do. And we would ask that you also bear in mind that one of the questions that will be coming up for us and has come up internally already is at what point is something and a whole OTP, and at what point is it just a medication unit? And similarly, what then would be the expectations? What would we hold the accrediting bodies to in terms of their reviews of the what would we expect from them in terms of their expectations of mobile units and medication units separately? So it is a complicated issue. We can't answer that right now. We need to hear from you and would like to hear from you about what's needed in the respective areas and how we might best facilitate responding to the crisis.
Okay, and thank you. That's fair. So given Patty's invitation, certainly, Patty, you'll let me know how I can guide providers to communicate with you or members of your staff.
If I could ask, Mark, I'm sorry, if you could communicate through your SOTAs, that might make it a little bit easier for everyone, because then it would also clarify what the state itself is willing to do.
Excellent point, diplomatically stated as always. So yes, I think, as part of our working relationship with the SOTAs and NASADEP is driven by a long-term partnership. And the partnership is about collaboration. So I agree. I think Patty gives you good methods of communicating. The SOTAs can be quite valuable. And our colleagues at NASADAT are extraordinary. And I'll just put in my 2 cents under a different opioid response network partnership, which is funded by SAMHSA. NASADAT and AATOD are doing a comprehensive review of the number of patients who are in treatment, which patients are getting specific medications, even the form of the medications that they are taking. So NASADAT is a terrific policy partner, but they're also collecting this information. And for my contacts over at NASADAT, I think they're past 1,300 programs. The reason you may not see this as clear, it's very important to get a picture of how many patients are actually in treatment at the OTPs, because we're going to be expanding access to care. As Patty knows, more OTPs were opening, even 50 during COVID-19 in 2020, and we have 1830 programs in the country. I think they're treating well over 500,000 patients, and it's probably more than that. That's what the census will get. So another question. For individuals transitioning from jail to halfway houses or recovery homes, did you experience any problems with these programs accepting individuals on medication-assisted treatment?
So we have, and that's an ongoing problem. It is getting better, and more recovery housing programs and are more open to MAT, but it has been a problem and continues to. It's one of the reasons why we actually opened our own recovery house, to give greater access to folks.
And folks at Evergreen?
I can just reiterate what Michael said. That's been a consistent problem for us as well. It does seem to be improving over the last 5 years or so. We have a little bit more access, but we continue to have problems with folks on MOUD, getting into halfway houses, detox facilities, inpatient facilities. All of those continue to still want our folks to taper before they're entering their programs, which is really difficult for individuals that need this form of treatment.
So keep in mind, you state opioid treatment authorities as these advanced systems expand, that be aware that these policy issues are quite important. And this has come up on some webinars we've been doing for Florida courts. As a reminder, for any sort of halfway houses or residential settings that get access to federal grants, it is illegal for them not to accept patients on MAT or to require detoxification. So please keep all of that in mind. Florida court judges and other judges, interestingly, remind me of that all the time. So as we've set up collaborations with people in the justice system, we've also found terrific partners in people, whether it's American Correctionals or the National Commission on Correctional Healthcare or national sheriffs. Interestingly, we're getting a very positive response from these policy partners because we have an interest in expanding access to the justice system. And Michael outlined that. The vision here is, as you saw Michael, and how that connection of the van getting into the compound, that can be done. And there's an interest. I think the DEA clearly has an interest in that because you have the OTP as the official registrant. They have to work with their state opioid treatment authority, perhaps the state alcohol and drug abuse director, certainly the Department of Corrections in the state. So dealing with the state opioid treatment authorities is really a pivotal piece. But again, you're dealing with policy impediments, and that's the nature of the question. Next question. What are the capitation requirements and the number of patients being treated? So if the OTP has a 350 patient cap, do we have to get another cap approval for mobile services, or is this included in the agency's overall cap? Now, just to be clear, I don't think that's a DEA or SAMHSA concern, although I invite our associates to respond. That is, however, a state regulatory issue. So federal government, this is your opportunity to correct me, federal government agencies, obviously SAMHSA, DEA, do not have a cap of how many patients can be treated, but states do in some cases. And again, it goes back to the state authority issue. So I will again encourage SAMHSA DEA to respond if they have any issues here. But I believe that is an issue, not for the federal authorities, but to the states. Would you agree?
That's
Yes.
correct. That's not a DEA issue.
And Patty?
Yes, I agree.
So for the programs, especially to that questionnaire, if your program has an interest in doing this, then you have to go to that state authority. Okay, with regard to take-home medication, how are the doses handled if the individual is released or transferred from jail? And is it placed back in inventory?
Just with, as with any take-home bottles, they're returned back to the OTP and we destroy them, following all the DEA regulations.
Okay, now this is an important question too, and this goes to the heart of why folks from third-party reimbursement authorities are on the phone, and this is something, again, for the state opioid treatment authorities to deal with. But it's relevant to SAMHSA as well. It's not, SAMHSA is really an agency about grants, and Ann Herron has gone through what can be done and what can't be done. This is about how a reimbursement arrangement structured for Project Kickstart, who pays for the MOUD and related services.
Yeah, so as I had said, we had original funding that went back to 2008 to provide services in the community. When we built our two new outpatient programs, OTPs, we really didn't need the bus anymore. There was access to the brick and mortar locations. And so we basically took the state funding that we had and we were able to apply it to the services at the jail. So it's state funding, and that funding does come through the feds, but it's state funding. And then as a result of the success of our project, which was a pilot project, some additional funding came through, also through the state, where we were able to increase the number of people we were serving. And we were also able to add on those additional care coordination and peer recovery support services. So it's state funding, and we have in total about $1 million worth of state funding that is supporting the project.
Okay, and this remember, there are two sections about money in this regard. First section is buying the van. The second section is reimbursing for services that keeps the van operational, because programs cannot provide services without a proper reimbursement. And
I should also say, Mark, that in the state of New Jersey, while people are incarcerated, they don't have access to Medicaid.
right.
So we couldn't use Medicaid reimbursement to pay for the service. So the funding would have to, has to come through state dollars.
Right, and also, which brings up the fact that there is federal legislation that's been introduced that will remove that Medicaid exception. Legal Action Center has been working on this with a number of our other partners in this area, and obviously we have been supporting this too. So this looks like it's a question for Ann. So just for clarification, can mobile units be purchased by OTPs through state opioid response grant funds?
So the simple answer is yes, but of course it's never quite that simple when you're dealing with funding and approval processes. So the state would need to submit their budget request justifying the purchase of the mobile unit. We would look at reasonableness of cost and make a decision at that point. So generally speaking, yes, give us the details and we'll take a look.
Okay, this is to our associates at the DEA. How long would it take to receive a response on an exception request? Which means this is the exception request about vans returning to the home site at the end of a day.
That's going to be on a complete case-by-case basis, depending on if they meet our requirements when they make the request, or if other requirements we put on them. That's completely case by case. We couldn't give a time frame on that.
Okay. And the question now, this is more like for the state opiate authorities, but Sam, so you should be aware of the question coming in. Will the states have to change their regulations in order to address the application for mobile van usage? So I guess, Patty, the question to you would be, is SAMHSA going to give the states any guidance or direction on this? Or, and I know from my colleagues listening at NASADAD, and you can't answer that question now, but we'll discuss it, about what would have to change for states in order to process applications for the use of mobile vans.
So yeah, yes, we will be considering the policies and considering all guidance. And again, we are listening to these questions and looking for what are the particular areas, and looking forward to hearing back from our SOTAs about their specific states' needs. So yes, we will be providing guidance.
Okay. By the way, Patty, this is in response to your question about tell us what you want to know. So that's what they're doing, just to be clear. Are there any OTP services that are restricted from being provided through a mobile medication unit? That's to you, Patty.
So I'm sorry, is that I didn't hear the first part of it.
So are there any OTP services that are provided at OTPs but are restricted from being provided through a mobile medication unit?
So again, the policy that is under review and being considered is that only medication dispensing and toxicology specimen taking is allowed at the moment, but that is again under review and consideration.
Okie doke. This is to the providers. How do you adjust medication doses on the mobile units? At my bricks and mortar OTP, patients see the NP if they want to increase or decrease dose. How does that happen? The patients being treated through the mobile units.
For us, those individuals will still need to meet with their medical provider, and that is typically done at the brick and mortar.
Okay.
Yeah, so for us, it's, as I said, we do provide counseling services. We have counselors who are embedded in the jail. They meet with clients in the jail, and they'll schedule an appointment for the client to meet with the medical provider.
Okay, this also for the providers. Do you have any tips, suggestions, or lessons learned around security in these vans, given your many years of operation, in addition to how panic buttons have been used, the alarm safe, example, not providing mobile unit personnel with the safe combination? So this taps into your experience as a sort of guidance.
Yeah, we have not ever used the panic button. So I'll just put that out there. That's not an experience we've had. And lessons learned for us with security is really making sure to hire the right people. We've had some experiences in the community where our teams are maybe a little more, what's the word I'm looking for? Assertive than they need to be. And that has impacted our relationships with patients and with community providers. So making sure that you have folks that understand the role, that are compassionate, that are focused on the mission that you're undertaking is really important. Not to minimize the importance of safety, but also recognizing the work that they're doing and the populations that they're working with is really important. I think that's the biggest lesson we've learned.
And Mark, for us, with the current use of our mobile unit, where the medication is well secured, and we're transporting it directly from the OTP to the jail, and then once we get to the jail, we're in a very secured location. And so again, the need for security there, you have the jail securities already present. So and then as soon as we're done dosing, everything's locked up and we go back to the OTP. So there haven't been any security issues or problems.
Good point. Also, this looks like it's a sort of Patty question, but more an AATOD question. I'm not trying to wear you out, Patty. But this really is an AATOD state authority question. Don't the satellite medication units and mobile van units need to be approved by the SOTA first? I think the answer to that is yes. And then this is an interesting question. Will states opt out, or can they? Will SAMHSA allow the states to opt out of using these medication units, even if OTPs want to have them? And so that's an interesting question. Rob, you may want to think about that with Melanie and Doug, but Patty, I guess that's a sort of, you may not be able to answer that question now, but I know you're marking up policy.
Yes, I am taking in all the questions, and thank you for the question. And it certainly will be an interesting one for discussion.
No kidding. Okay. Next question. We are a federally qualified health center. How would this work for us? We most likely would dispense the medications. That's a sort of Patty and question.
Mark, would you be kind enough to repeat that? I don't think I understood the question.
Sure. So this question comes from a federally qualified health center. How would the mobile vans work for us? We most likely would dispense all the medications. They just want to know if they could qualify.
So they would have to qualify as an OTP, or I would think that as an FQHC, they might have a waivered prescriber on board. If they are doing, if it's hard to understand the situation without, to best answer it without more information. An FQHC that has a van that goes out to the community might want to be able to have a waivered prescriber on board.
Okay. There's a question about, would these mobile vans be applicable for Puerto Rico? I think the answer to that would be yes. And Puerto Rico already has van services. But what do you say?
I would think so.
Practical question is, can someone provide an estimate for the costs of setting up and operating a mobile unit? Is this something you could feasibly set up without external funding and support? Also, are there reimbursement differences between services delivered at the mobile unit versus a brick and mortar location? And that's for the providers.
Well, I think we already discussed the cost of the van itself, and then obviously you're going to have your staffing costs and so forth. So as I said, we're not funded through Medicaid, so I can't speak to that issue to provide those services, since we're providing services in the jail. But yeah, you're going to have your van costs, you're going to have your staffing costs, etc.
Okay.
And for us, we do bill Medicaid for services that we're providing. Our reimbursement at this point is a bundled rate, and that bundled rate definitely does not cover the full cost of the services that we're providing in the community. It is an increased cost because you have additional security folks and staff positioned on the van. And so for us, we have definitely had to rely on secondary funding from grants, in-kind donations, those kind of things for us to be able to maintain our service.
Okay, one last question also to providers, then we'll close out. Did you have any resistance from staff willing to work in the smaller space of the vans as a result of COVID-19?
Yeah, that's been a challenge across the board, not just in the mobile van, but it's been a challenge in our brick and mortar sites as well. So, and certainly in the jail, it's made movement challenging. It's made scheduling individual and group counseling sessions, doing assessments. I mean, it's made everything more challenging. And of course, there's been several times when in the jail, there's actually have been the entire jail has been quarantined due to COVID outbreaks. So yeah, I mean, it's across the board made everything more challenging.
Yeah, and we had to pull services back completely from the community. We utilized our mobile unit up until this point. We're still doing this. We've utilized our mobile unit as a location where we are able to provide services to folks who are symptomatic or who have tested positive as a way to keep them out of our locations, but continue to provide services during this time. So it has provided a vital service during the time of COVID, if you will, but we definitely have not been able to utilize it in the community due to those concerns.
Well, keep in mind, as I sort of wrap up, that there are always challenges in how we work in the system. I've spent over 40 years doing this work. I've never had a boring day or a week. There's never been a time without challenge. That comes with the territory, but we push ahead because that's what we need to do to treat our patients. And as already has been said, the mobile van services can also be holistic in nature. This is not only a medication unit requirement, this is fairly broad. And that's part of our encouragement. We'll again be releasing a policy paper following Labor Day, which will embrace and discuss these various components. So for those questions we could not answer, I'm aware of them. We will get you responses from our panelists. To our panelists, my gratitude for your willing to share your knowledge, your experience. To our associates at the federal level, again, our ongoing collaboration is terrific. And I am always grateful. As many of my colleagues know, I never take anything for granted because we shouldn't. And this is an ongoing issue. There are many other opportunities for us to expand the access to treatment, which we need to do throughout our system of care. There's going to be a brief survey at the end of this, which is now. So please stick around, answer the survey questions so we know how to gauge this in future webinars. I know that there will be ongoing discussions and policy work between federal and state authorities. And I know that our colleagues at NASADAD and the state authorities will work effectively with the programs to get this moving. This took a lot of effort, and I don't have to tell the DEA folks or SAMHSA folks. In my work over the last 35 years with federal agencies, it's like working with an aircraft carrier. It sort of turns real slowly. But when that aircraft carrier turns, all the fish know what's going on. And that's an important part. You know, for people who think that federal authorities are supposed to move on a dime, that's really a mistaken notion. They're not. They're supposed to be deliberative, thoughtful. They've got to be careful, because if they screw something up, it affects the entire country. It doesn't affect the state or municipality. So that puts the federal agencies under a sort of special purview. And I appreciate that, because the same generally applies to me. It's easier to critique something than actually to create something. So with that, I know that Angelina Budia, who's our coordinator of these efforts, and I'm always grateful to Angelina because it takes a great deal to get these things set up. Ultimately, this has all been recorded. The recording will be made available to all of the registrants as well. We will also send the recording out to the over 9,000 people through our contact network, so they can be made aware of it also. So again, in closing, I'm grateful to all of our panelists. You've been terrific. You've provided great information. To the providers and participants on the call, please keep in mind this is the beginning. Remember, DEA released this June 28th. It became operational on July 28th. This is August 11th. We wanted to have this webinar available to you as soon as practicable after the operational dates. I know there are questions which have been put about funding. Yes, there was a question about, will we provide the resources about manufacturers? We will. We'll get that information out probably at the end of next week. But as I said, this is a new opportunity. I'm advising our colleagues to fully use this opportunity. You've gotten the value of our provider colleagues in New Jersey and also in Washington State. So my recommendation is follow up on this. AATOD will provide resources for sure. That's what I suggest. Now, Scott, is there anything else you'd like to say to close before we close out?
Yeah, there was one thing to add. You guys talked a lot about the state requirements for the NTPs. You have to remember that in order to get a mobile component approved through DEA, you have to have state authority to do it. So if your state doesn't have the authority to do the mobile component, DEA can't approve the authority for you to do the mobile component. And I think that's an important part with the state regulations. And then I did see one really important question that was going down the side there is, can they leave the state? The important thing to know is that your mobile component cannot go across state lines. That's very important for everybody to understand. So those are the things I had. Thank you.
Okay, that's an important point. Yes, if you're operating the van and if it's coming out of the hub facility, which it has to, you can only treat patients within the state that has the hub van license. So that's an important component. And I know the question that came up on June 28th is, suppose the van is going through an interstate highway and has to come back into the state. That's not a problem as long as that van is not stopping in the other state to provide services. The van operating on an interstate is okay, but they can't be providing any services, just to make a fine point in addition to what Scott said. Okay, that does it for us. Thanks again. I appreciate your patience, certainly your participation. This demonstrates the collaborative nature, by the way, between federal agencies, state agencies, treatment providers, and this is all designed to expand access to care for a patient population and to then tie in treatment with justice, which is what a part of JCON is doing, certainly LIDA with Tisha Wiley and her associates, and certainly our colleagues at the American Academy of Addiction and Psychiatry through their Opioid Response Network. With that, I conclude. Thanks again. You'll get the recording. Please fill out the survey. Be well.
Thank you.
Yeah.